So it's a great pleasure to introduce Professor Andrea Genazzani. He is born in Florence. He did his medical studies in Siena University, then became a gynecologist and an obstetrics and specialist, and he worked in endocrinology and metabolism. In 1972, he received a PhD in clinical biochemistry at the University of Lausanne in Switzerland. He has then gone through all the steps of a very distinguished career. He started as assistant professor in Siena and then moved to Cagliari, and then he became associate professor in Siena again, and then professor in Cagliari, and then he was the head of the Department of Gynecology in Modena, and then since 94 to 2012, he was head of department in University of Pisa. For all his research, he was awarded a number of prizes, and I am particularly touched by the fact that 2 Romanian universities gave him Doctor Honoris Causa, among which the University of Bucharest, which is the best university in Romania, also University of Athens in Greece. He has been president and officer of many European and international societies. He has more than 830 papers and 45 books. And with that, I thank him really very much for being with us today, even virtually, as he unfortunately had COVID and had to be not coming here today. Thank you.
Yes, I am really, as you can imagine, I am really sorry not to be with you, mostly because I have lost a fantastic opportunity to be close to Jean-Michel Foidart, to join back at the Royal Academy of Medicine that honored me with my membership, and also to have the pleasure to share my time with you, and mostly to share my affection with Jean-Michel. Today I will speak about you on a topic that I am working on in these times, is estrogens and female brain. We are always, as a man, we are always fascinated what are estrogens effect on the brain, on female brain, and what they should be the difference. And then I will, I will start by that consideration. This is something that we were not so aware in my younger time, that the fact the brain intracerebral content of steroid depend from the output coming from peripheral endocrine glands, but also depend from a local synthesis. Either central nervous system as well peripheral nervous system are both able to metabolize cholesterol to pregnenolone, and from pregnenolone, according to the expression of selective enzyme important for the steroid metabolism, to produce selective steroids inside to the brain. The brain is a steroid-producing organ, as is also the adrenal gland or the ovary, but it don't need any proteic hormone to activate it. This is directly activated by the fact that cells, a different group of cells, can express different quality of steroid metabolizing enzyme. This makes that locally you have a different production of steroids, which is dependent from the genes activated by the singular cell. Then the intracerebral steroid level depend from that local production to general output and the intracerebral metabolism. What are the mechanisms by which sex steroids impact on the brain? First, I would like to start with the organization. As you know, we are all born with a female brain. But we men, we have a transformation of our female brain in a male brain, which is dependent from the testosterone production from the testes of the fetus. The testes of the fetus producing testosterone modify the structure of the brain. And this is reinforced at the 3rd, 4th months after birth by that time where we have a small pubertal activation will bring a further increase of testosterone just after birth. Then steroids have an activational effect. They are very important to modulate the neurotransmitter function, to activate the receptor subtype crosstalk. They're able to induce receptor, and they have specific genomic and membrane effects on all kinds of cells living in the brain. They are touching the oxidative metabolism, they are responsible for the control of apoptosis, and they have specific cellular effects on neurons and on glial cells. They are able to produce the expression of synapses, they can control inflammation, and they have a very profound neurovascular effect. What are the non-reproductive central nervous system function impacted by sex steroids? You can see how they are important, mostly if you make the difference between humans and other primates. The affective state, mood, sleep, libido, sexuality, social behavior, the motor coordination, the neuronal excitability, the pain threshold, the auditory threshold, the cognitive function, and they have also multiple mechanisms for neuroprotection. When I have spoken about the CNS sexual dimorphism, this is dependent from the different expression of the various brain areas of estrogen, progesterone, and androgen receptor on their polymorphism and on different specific steroid metabolism who occur in the different nuclei. We have also structural sex difference who imply different neuronal subpopulation in brain areas. And this brings to what? This brings to a sexual orientation, to the gender identity, to the cognitive dimorphism, to the specific response of hormone therapy, and also to the different prevalence of neurological and psychiatric diseases. But you can see, speaking about estrogen, the most important estrogen, apart Estetrol, we will go back on that one, is estradiol in women. But you can see that women, they have very profound difference in their estradiol level. If you go from follicular, ovulatory, and luteal phase, where we have some 10 or some 100 picogram per ml, we go to the pregnancy where we have 1,000 until 40,000 picogram per ml, and for more than 30, 35 years, postmenopausal women, they go back to concentration of 10, 20 picogram per ml. How we can believe that this can have effect, positive, negative, different according to their concentration in their life? And also, what we have seen is that the brain shows a specific vulnerability, which is dependent from the sex steroid withdrawal. After menopause, women, they have a reduction in the brain in the expression of CRH, of propomelanocortin-related peptide and vasopressin, and increases in central noradrenergic system, while they have a reduction in central dopamine, serotonin, acetylcholine activity, and also a reduction in allopregnanolone production and then in the GABAergic function. And this brings to what? This can bring to some signs and symptoms who are specifically dependent from the individual. This is the new concept of the individuality. Vulnerability depends from an individual fragility. And this can be associated to stimulation of symptoms such as irritability, anxiety, fear, depression, fatigue, psychosis, decreased seizure threshold, but also hot flashes and autonomic hyperactivity. And this depends to what? When we speak about the symptoms of the menopause that we have resumed in that review that we published on Nature, you can see here they have central nervous system, skin, mucosal, and hair changes, changes in sexual function, in weight and metabolic changes, in urogenital system, and in musculoskeletal. But if we go to see the central nervous system, which are who clearly indicate the great sensitivity of the brain to the hormonal changes, they are vasomotor symptoms, but also sleep disruption, depression and anxiety, cognitive changes, and migraine. But all these depend from specific activity. The vasomotor symptom and the sleep disruption depend to the increases noradrenergic activity with a reduction of dopamine, serotonin, and important in cases also of neurokinin, kisspeptin, norepinephrine, and cortisol. And if you go to see what are the causes of the mood and cognitive function changes and changes in neuroendocrine activity, still the imbalance between growing noradrenaline and reducing dopamine and serotonin, but also a reduction in GABAergic function, a reduction in beta endorphin, in allopregnanolone, in all estrogen and androgen, and an increase in cortisol and increase in amyloid B. And this brings to the fact that if you look what happened in the different biomarker in peri, po, and post-menopause, you can see here that we have selective changes in biomarker production, such as an increase in ATP, an increase in amyloid, changes in cerebral blood flow, changes growing of gray matter, why we have a reduction in white matter volume and in fractional anisotropy. And we have a reduction in glucose, cerebral glucose metabolism. All these indicate that these biomarkers indicate that we have a central general adaptation to the lack of steroids happening with the menopause. And one of the major chapters of our interest, which is associated to the fact that it is a huge health problem for health authorities, how to manage dementia in a growing population, is the fact that the observation that the prevalence of dementia is growing dramatically due to the aging population. All causes of dementia, different underlying pathophysiology, Alzheimer's disease, vascular dementia, there are many risk factors at that time. And when we see this in that nice cartoon showing in the left side, the number of people with dementia in low and middle income countries compared to the high income countries. You can see here how in low and middle income countries, the number are growing in a more faster way than in high income countries. And also, it is important to see what are the percentage of dementia touching the both genders, females and males. You can see here that females have a significant increase in the fraction of demented people in ages going above 75 to 84, and even more over 85. And as you know, the longevity of women is even bigger than men. Then this creates a huge, very important health problems. And very recently, it has been reinforced, the concept of the importance of the steroid depletion by that fantastic study that done by a friend of us, Walter Rocca in Mayo Clinic. They have two cohorts with bilateral oophorectomy, one of female with less than, who had bilateral oophorectomy at less than 55, and one who had an oophorectomy at 45 or less, who were followed for 14 years. And then the outcomes shows that the incidence, according to the time of the oophorectomy, you can see that overall mortality is significantly higher hazard ratio in those who had less than 45. The same is also for cardiovascular mortality, but also the same, very important, is cognitive impairment and dementia, that as early as be done an oophorectomy, as greater is the risk to develop dementia and other pathological processes. And this brings to the concept that the bilateral oophorectomy activate the aging process, activate the accumulation of senescent cells, the senescent cell-derived protein, the inflammation, the protein aggregation, mostly beta amyloid, the mitochondrial dysfunction, the epigenetic alteration, the telomere attrition, the empiric signaling, the stem cell exhaustion, and this bring to a multimorbidity. The multimorbidity, I cannot go in details for time. They can touch the brain, they can touch the cardiovascular system, other somatic. I mentioned only the arthritis, for example, and also the development of diseases such as asthma, osteoporosis. But you have to take care of the brain, of depression, of anxiety, and all these who indicate the sensitivity of the brain, such as the cardiometabolic, the impact on diabetes, hypertension, hyperlipidemia. And all these stimulate the frailty and stimulate the reduced health span. Then we have a precise link between the damage done by early oophorectomy. And in 2002, it was published in JAMA, that very nice paper, in the same year when they published the WHI, very bad study, but in that study, they evaluate the incidence of Alzheimer's disease in the beautiful county of United States, the Cache County, in women and men. You can see the difference. Population going from 65 to 95, women in red, the men in yellow. It's a huge gender difference. But if the women, they were submitted to hormone replacement therapy, you can see what happened. In violet, the hormone replacement therapy non-user, then in green, less than 3 years, 3 to 10 years of treatment in blue, and in pink, treatment for more than 10 years. More than 10 year treatment cancel the gender difference in the incidence of the disease. And the same author, they went to have make a reanalysis and have make a longer follow-up of their study, evaluating the endogenous estrogen exposure, who was calculated talking the reproductive window in the age of the menarche to the age of the menopause, adjusted for pregnancy and breastfeeding. And they have found in that fantastic study that longer duration of endogenous estrogen is associated with better cognitive status in older adult women. And these effects are extended with hormone therapy use, particularly among the oldest women in our sample. And women who initiated hormone therapy earlier showed higher cognitive test score than those who initiated hormone therapy later, providing some support to the critical widow hypothesis of hormone therapy. And at the same time, a series of studies have shown that the treatment done in recently menopausal women don't change the cognition, but there were studies done for they have a short time duration. And in another study, Pauline Mackey and Victor Henderson, they publish that position statement from North American Menopause Society that estrogen may have positive cognitive benefits when initiated immediately after surgical menopause. Women with premature menopause are not well studied, but also they tell that hormone therapy in early natural postmenopause period has neutral effect on cognition, and hormone therapy cannot be recommended at any age to prevent or treat dementia. This was published in 16 and 17. But look, going on with the new investigation, Tommi Mikkola from Finland, he found that data on vascular dementia death and the exposure to hormone therapy. Please look the risk on your the right column in the exposure age of less than 5 years or more than 5 years for the vascular dementia. This is another chapter, the effect on the vessel, have a preventive effect at any age and for any duration. And if you go to look what kind of population was treated, if they were less than 60 or more than 60, you can see that either any hormone therapy or estradiol only or estradiol plus reversing, all of them, they show a very important protective effect on vascular dementia death, which were also the vascular effect of estrogen are important. If the same author went to evaluate the risk of Alzheimer, of death in Alzheimer's disease, you can see that there is a difference. This indicates only the longer treatment, more than 5 years, have a positive, have a reduction effect. And this happened mostly in younger individual and mostly younger individual and slightly less in above than 60. Then there is a difference in the response to hormone therapy according to vascular and Alzheimer, but Alzheimer dementia need a longer treatment. Alzheimer estrogen are able to influence both beta amyloid and tau proteins. This is something, biologically speaking, very important, with direct effect on neurons and action against neuroinflammation and oxidative stress. And but it's better and it's important to understand the early stage pathogenesis of Alzheimer's dementia. Is there a window for estrogen in Alzheimer's dementia? This remains the question. But when we go to see the amyloid deposition, and you imagine and you look at this beautiful picture who compare postmenopause, menopause, peri, and perimenopause, you can see here that human menopause is a dynamic neurological transition that significantly impacts brain structure, connectivity, and metabolic profile during midlife endocrine aging of the female brain. This is important. When I speak, the female brain have to face the aging process with the damage, with the fact that the menopause really introduces a steroid withdrawal. And if we have a replacement, this is a beautiful study from Roberta Brinton-Diaz on the association between menopausal symptom therapy and the risk of neurodegenerative disease in general. Alzheimer disease, Parkinson's disease, dementia, multiple sclerosis, amyotrophic lateral sclerosis, you can see in population who had oral or transdermal therapy in comparison to control. Please look how significantly, independently, and from the way of administration, oral or transdermal, stronger by oral way, all the neurodegenerative diseases are touched by the treatment. Then the treatment reduces the incidence of neurodegenerative diseases. And the result of the study was the use of hormone therapy associated with significantly reduced risk. Hormone therapy with natural steroids, everything beta estradiol or progesterone, were associated with greater reduction in NDD risk. Oral hormone therapy users show a significantly reduced for combined NDD compared to non-hormone therapy user, and the relative risk for transdermal hormone therapy user were significantly decreased for all causes of dementia and multiple sclerosis, and the greater reduction in risk of NDD, Alzheimer dementia emerged in patients aged 65 or older. And protective effect on long-term therapy, more than 1 year. We believe now the treatment have to be done for 20 years. On combined NDD, AD, PD, and dementia was greater compared to the short-term therapy. But then now I would like to finish with some data that we have produced about the Estetrol. Estetrol, it was discovered many years ago. I was working on that at the end of the 60s and beginning of 70s. Then I went back later on when Jean-Michel Foidart offered me the possibility to study the effect of Estetrol on the brain in animal models. And as you can see here, Estetrol have this peculiarity to be produced by the fetus and to have high concentration in the fetus, where you have to define the fetus from the very high estrogen exposure, and also high concentration in the mother. But what does the human fetus, why produce Estetrol? I think that we have to go back to Aristotle. Nature does nothing in vain. Certainly we have to discover the precise role of Estetrol. But then looking what is to the pharmacokinetic data, you can see here that they have a characteristic to have a very long half-life. Then you have a very maintained the exposition, and they remain a long time in peripheral circulation, who providing an easier way of action. And we have evaluated the effect of Estetrol on the production of allopregnanolone. Allopregnanolone is a progesterone metabolite, which is important for its effect on GABAergic system. It's the most important endogenous antidepressant. And estrogen affect the allopregnanolone production by inducing the enzyme responsible of the metabolization of progesterone to allopregnanolone. And we have evaluated in various brain areas. And you can see here, this is the comparison in castrated rats of the effect of estradiol valerate 10 micrograms or 50 micrograms in different brain areas. This is frontal cortex and parietal cortex, and 1 milligram or 5 milligram per kilo per day of Estetrol. You can see that given that Estetrol have the same effect on the brain, stimulating the production of allopregnanolone in frontal and parietal cortex, stimulating also with a stronger action in the hypothalamus and in the hippocampus, then it maintains this effect. and also in the anterior pituitary and in peripheral circulation. Then estetrol have maintained this profound effect to stimulate the production of the most important GABA-A agonist steroid. And also in another area where our lab was working in the last 20 years is the production of endogenous opioids. And also for the endogenous opioids, this is the comparison between, in castrated rats, the effect of estradiol valerate 10 or 50 micrograms or 1 and 5 milligram of estetrol on the production of beta endorphin. And you can see here that also for beta endorphin, either in the hypothalamus as well in neurointermediate lobe, estetrol have a potent stimulator. And this is in the anterior pituitary, and in plasma, you can see the different, they have a different effect in comparison to estradiol in the pituitary, but in peripheral circulation, we have an increase of beta endorphin after estetrol administration as it was for estradiol. Then I think, ladies and gentlemen, what is our conclusion today? I would like to bring that slide that we recently published on Human Reproduction Update on our vision of hormone replacement therapy in women. And I would like to put in that chapter also the great importance to see the data that are now appearing on the effect of estetrol as estrogen. In healthy women or in women with early menopause, we have to start the treatment, and the therapeutic options are such that the treatment start with estroprogestin sequential or continuous oral, transdermal or transcutaneous, and different also other therapies. They have to be revised after 10 years, not stopped, revised, readapted, titrated to the needs of the patient, and she can continue also going on until very, very old age. But in women, we have already risk factor and comorbidities. Then we have to evaluate the proper treatment. And the proper treatment is to go according to the nature, not to go oral treatment, but to go, if possibly, to go transdermal or transcutaneous treatment with estrogens and also with the transvaginal progesterone to permit the treatment, and to go in, and also in this patient 10 years after, to make a recheck, a reevaluation, and to see evaluate the possibility to continue the treatment. The possibility that estetrol offers now, by its lack of effect on the liver, is the fact that also in women with different comorbidities, we can maintain oral treatment if we will have from clinical results and for the result of the studies going on now, a positive, we maintain the vision of that absence of effect of estetrol on the activation of clotting factor by the liver. Then, ladies and gentlemen, I think that we have now new concept about menopause and aging. We have to rewrite the dynamics of aging process, and we have to remind that to maintain steroids mean to maintain the course of nature, and changing is different than aging. But I have also to remind you that no data indicate that in women who well tolerate menopause hormone therapy, we have to stop it. We have to adapt it, and we have to try to make treatment to protect the humans from that terrible incidence of dementia and Alzheimer, who are touching our population in a time where we have no more the possibility to take care of ourselves, and the disability in elderly is a terrible problem. We have to prevent that one. And I think that in the prevention, estetrol can have a very important word. Thank you, Jean-Michel. Thank you, ladies and gentlemen. I'm sorry, for COVID, I was obliged to remain at home. My heart is very close to you, and I thank you very much for your attention.
Thank you very much. Thank you very much for this wonderful talk. We appreciate your effort, and now we're going to ask for questions from the room here, if there are questions. Yes?
Professor Christophe Sotiriou.
Can you hear me?
Professor Sotiriou, yes.
Thank you. I don't know if you can see me anyway. Can you hear me? So thank you very much for this great presentation. I've been medical oncologist and treating breast cancer. So you didn't say anything about you know, potential contraindications of hormone replacement therapy for, you know, for postmenopausal patients, women and breast cancer. Do you have any comment on that? And if there is any difference according to estradiol replacement therapy or Estetrol, you know, the first time that I heard today.
Thank you. Thank you very much. This is the most important of them. One of the questions, probably one of the most important, because women, they have a specific fear about breast cancer. It touched the woman, not only for health problems, but also it touched the woman for their total body image and femininity. You know, certainly, as you know, we had several studies showing that it's not so much estrogens who have a greater importance in the breast cancer, but much the progesterone, And all the treatments done until now with estradiol only, they have indicated that the incidence of breast cancer don't increase. There are also some studies indicating that if you treat women only with estrogen, you can have also a reduction of the normal expected incidence of breast cancer. And also it has been shown that we have to use the natural progesterone, progesterone or dydrogesterone, which is the oral way of the stereoisomer of progesterone, not the progestin. The progestin, they're bringing with themselves some biological effects originating from their originating molecule, then testosterone, 7-methylhydroxyprogesterone, and by that way, they can negatively affect the breast and they can increase the incidence of breast cancer. Then I think we have to reanalyze all the data and go back. Now with Estetrol, Professor Foidart knows, we have that probably new aspect that Estetrol have less promoting is even better, but we expect the data, even better than estradiol. But I would like to go on the general concept. We don't have any data showing that hormone replacement therapy causes an increase of breast cancer if you use the proper way of administration, which should be probably transdermal, or if you use the proper progestin, which is progesterone, the natural progesterone or dydrogesterone.
Before yes, do you want to ask something else?
Another question, maybe an eighth question. Because we are, you know, sometimes we induce ovarian ablation for our breast cancer patients for 5 years at least. So you say that, you know, regarding dementia, regarding you know, central neural effects, are those reversible, and how long it takes actually to have this kind of problems when you yeah.
I thank you very much for that question. I thank you very much for that question. The limit of 5 years, it was never demonstrated to be real. It was the people, they were afraid in general by the data. But now we have seen that the proper treatment, mostly for the brain protection, but also for the cardiovascular protection, is to go above the 5 years, to go from 5 to 10 and from 10 to 15. And also we have seen that the women who are still maintain positive effect and don't have any adverse effect by the hormone therapy, they have to reduce the total amount, but they can also continue until their 8th and 9th decade of their life. It's not needed to stop.
Thank you very much, Professor Casimir.
Yes, thank you very much for your presentation. I have also a question because you show us the very impressive effect on the prevention of psychiatric troubles and disease in women. Why estrogen didn't use as a treatment, or try as a treatment in psychiatric disease?
I thank you, Professor Casimir. Fantastic question also, that one. You know, first of all, all the doctors, a part of the gynecology, are a little bit afraid by the use of hormone, also because the hormone, they can induce uterine bleeding. And if you use only estrogen, you know, this can happen. And how to manage uterine bleeding if you are a psychiatrist is always something too much difficult. This was my first observation. But also it is important to mention that estrogen, we are speaking about the estrogen withdrawal, then the lack of steroids in a brain which is well adapted to have steroids always present at different concentration. Certainly, the data with the long-term therapy with steroid after menopause, they are different in comparison to the use of estrogen in women who develop a psychiatric disorder such as severe depression during their fertile life. These are depending from specific vulnerability and specific characteristics of the female brain of that woman, where serotonin normally have a reduction in serotonin production, an imbalance, and reduction also in endogenous allopregnanolone production. Then I don't think that we can consider steroid as a treatment for a psychiatric disease, but we can consider treatment as a protection for vulnerable women who can develop psychiatric symptoms after steroid withdrawal.
Thank you very much.
Andrea, thank you. Thank you very much, Andrea, for this very nice lecture while you are sick with your COVID and you couldn't be with us. I wanted really to warmly thank you for this very elegant presentation at the time, which is very important for MITRA. And I see in the audience Graham Dixon, our Chief Scientific Officer at MITRA, who has developed with more just and the co-workers a very large comprehensive program on the neurological application of E4, including first in vitro studies on cells, on neurons and glial cells, but also in vivo in animals and also imaging in humans. And this lectures on the female brain is extremely beneficial for the audience, but also for the company. And I must say that I'm a little frustrated by your presentation because only women will benefit from estrogen. And what about the males? We don't produce estrogen, but our brain is still very competitive, no? And thank you very much for your lecture.
Thank you very much, Jean-Michel. I am so sorry, and my wife also, she's so sorry that we were waiting to join you and Marguerite and to be with you and with MITRA friends in Brussels. I hope that, I'm sure that in Florence we can discuss all about it, and we are waiting the new data that you are going on studying the effect of Estetrol in postmenopausal women treatment. I think this is of major importance. And also, I think it should be of great importance also to have an assessment in the use of hormone replacement, in the use of Estetrol in contraception. As you know, in contraception, they were appearing data from some Swedish colleague about the suicidal risk in younger population in the first months of treatment in general. And I think that Estetrol, the combination with drospirenone, who have no effect on endogenous inhibition of endogenous allopregnanolone production, and the effect of the addition of Estetrol can be also considered in view of a protection, specific protection of this association in comparison to the effect of other contraceptives.
I'm just a neurologist, so it's a very simple question. How does the amount of estrogen receptors evaluates in women after, because there was a woman as well as men, of course, but is there a decrease in the neural receptor? And is there, after menopause, a decrease in the...
I'm sorry, I don't hear the question. I don't hear the question.
I got the one. My question is, with aging and in postmenopausal woman, how does the amount of brain estrogens evaluates? Does it decrease? Is it stable? Does it increase? As well as the amount of estrogen receptors?
Thank you very much. Beautiful question. Okay, in the aging evolution, the total content of central estrogen is slightly progressively declining. The brain is not the same reduction as in peripheral circulation, because we have also a local estrogen production, which is partially maintained, but the mechanism is going down and the total content is reducing also in the even so they have some difference in the various areas, but it is declining. And related to the incidence of steroid receptor in general, this is a different evaluation that have to be evaluated in a different way, have to be evaluated according to the different area. The brain is a fantastic environment where you don't have the same concentration as in the muscle, as in the heart, in the different tissues. According to the different nuclear structure, you have a different local expression of steroidogenetic enzyme or steroid metabolizing enzyme. And this make that all the area who produces aromatase, you have a huge concentration local of that estrogen, while in a closer group of cells who don't produce aromatase, you don't have this one at all. Then it's important to evaluate the concentration area per area. But also with that way, a series of studies have shown that we have a reduction of receptors, a reduction also of the receptor for gonadal steroid. But this is sensitive to the administration of the steroids. As I remind you, the intracerebral content is depending from the flow coming from the periphery together with the local production. Then by the flow coming from the periphery, you can interact in the activation of steroid receptor. Estrogens, they can modulate, they can stimulate the production also of their own receptor.
No desensitization. No desensitization.
Yes.
No desensitization.
No, it's not apparent. The desensitization program is not apparent. There are only a few studies. I think it's an area which has been until now poorly evaluated. I agree with you.
Thank you. We have a question from the audience, Zoom audience. So Jean-Pierre Foidart will ask a question to you. He's a member of the Academy.
Hello, Professor Constantine. Thank you very much for the... Do you hear me? Yeah.
Yes, I hear you.
Thank you. A beautiful review of, especially on aging and the relationship with Alzheimer's disease. As you nicely did show, initially it was a bit controversial, the effect of estrogen on the frequency of Alzheimer's disease. It seems to be more documented now. But you mentioned the potential effect of windows. That would be therapeutically more interesting. Would you comment on the cellular effect of that? Is there anything in the hypothalamus, for instance, a difference or?
Yes, there are some studies who shows that the effect that we have to differentiate the study in humans as in animals. In humans, it is more clear that the administration in early stage of the menopause are associated to a better response of the individual, either with the different biological and also clinical evaluation. Then we have to start as early as possible, and the results indicate that as early you start, as better. But this is not true that if you start later, you don't have any results. You have results, but clinically speaking, of less importance in comparison to the other. Now, when we go to the animal, we have also to start with a reflection, a general reflection. The animal, they don't have the menopause. Normally, their life is stopped at the end of the possibility of the extent of their reproductive life. Only some whales have the menopause as women. Then the fact when we make the castration and we make the treatment, we make a picture who can be compared to the menopause. But this is quite different because this indicates that in the animal, you have a brain which is organized not to face that phenomenon. In humans, we have that prolongation of our lives. Our life now is 35 years more after the menopause is still existing, and we are still growing and probably will go on. And then for that one, it seems to be more specific, the protection, the concept of the window. Then as early you start, as better you have your effect. But no data shows that if you start later, you don't have any effect. You have minor effects.
Okay, thank you. Thank you.
No, it's my pleasure. Thank you.
Do we have any other question here in the audience? No, and we don't have any more questions on internet. Professore, lo ringraziamo, penso che la giornata è finita, adesso si può andare a riposare.
I will remain with you. It's so beautiful to be together, even though with that distance. I thank you very much, Jean-Michel. I was honored by that invitation, you can imagine.
No, you can still come, Professor. This is not a problem for us. You know, here in Belgium, you're always welcome. So there's no need of a conference.
Thank you very much.
Thank you so much. So